Hello and welcome back to another research recap. My name is Lisa. I'm your host. I'm the owner and operator of Nutrition Coaching and Life. And today I have with me Calvin Scheller. Calvin is a contributing author to the Alan Aragon Research Review and just generally someone who loves digging into the research. Calvin, I'm so excited to have you on today.
Likewise.
Well, I'm very excited about our topic also. We are going to talk about all things GLP-1. And while that is a term that has been thrown around all on social media and elsewhere, very few people actually know what that means, what it does, how it functions, how it should be used, and so on. And Calvin is going to shed some light on all of this for us. So please, a little bit of an introduction into GLP-1, and then we can dive deep.
GLP-1, like most hormones, is a protein. So GLP-1 is considered in a broad classification of hormones called the incretins. These are hormones that are produced inside of the gastrointestinal tract in response to food intake. So when we consume food, specific nutrients inside of that food stimulate the release of GLP-1 from specific cells located inside of the intestinal tract. And then one of the main effects of GLP-1, as many people know, is a reduction in appetite. So most of the incretins have an appetite suppressing effect, but it appears that GLP-1 is one of, if not the strongest appetite suppressant, which is why some of the new medications, as some people may have heard of semaglutide or brand name Ozempic and Wegovy, those things are GLP-1 receptor agonists, meaning they act just like GLP-1 inside the body. So GLP-1 is one of the strongest appetite suppressants we have, and the release of GLP-1 is stimulated by food intake. And the intake of specific nutrients or specific structured foods can alter our GLP-1 response to a meal, which is why some meals may feel more or less satiating, even with the same energy content.
Awesome. Well, that's a really great introduction. And I think most or many people even just think when they hear GLP-1 now, they straight away associate it with the drug as opposed to something that is already present within the body. And it's so interesting how you also say that the release is different depending on what we eat. I think that that probably plays into or is kind of the Kickstarter for various satiety indexes of different kinds of foods. And I'm such a big fan of looking more into that when people diet because oftentimes, just like you say, we have the same calorie content for one meal versus another, and people are like, "Oh, I'm so hungry on, this protein bar and maybe some banana or so." But if we exchange the same amount of calories, let's say in this example, maybe 350 for a big bowl of greens and some chicken breast and a little bit of sweet potato, you might feel a lot more satiated. So I'm huge on looking into the satiety index. But okay, nonetheless, in regards to all these drugs and everything else, talk to us about the research on this. And from what I hear, it's actually something that's been tested for a long time. But why is it becoming or has become so popular now?
Importantly, GLP-1 receptor agonists. So these are molecules that can bind to the same receptor as the GLP-1 that we produce and induce the same effects. So we may have the same production of GLP-1 inside the body, but with these medications in our system, they're activating the receptor at a higher magnitude. The thing about GLP-1 receptor agonists is they weren't originally developed and still a lot of times aren't marketed towards weight loss. They were originally developed for diabetes because one of the main functions of GLP-1 receptor agonists or GLP-1 itself is to bind to receptors on the pancreas that increase the production of insulin, which makes sense as because GLP-1 is an incretin, we want to produce insulin after a meal in order to regulate our blood glucose. So in very simple terms, insulin is one of the most important molecules for getting the fuels outside of or that are inside of our bloodstream out of the bloodstream into our cells. So it will increase the consumption of glucose by our muscles and our liver and increase the uptake of amino acids and fats. So GLP-1 appears to increase insulin production, which for diabetics who have abnormal blood glucose control, meaning their blood glucose is too high at the moment, an increase in insulin production can help them regulate their blood glucose better. So these drugs were originally developed for type 2 diabetes, and the original medications weren't, they were a little bit different than GLP-1 receptor agonists. They were actually considered DPP-4 inhibitors. So they essentially inhibited the enzymes that broke down the GLP-1 that we naturally produced. So those medications started off, they essentially extended the half-life of the GLP-1 that we produced after a meal. And then once those showed a little bit of efficacy, we began kind of looking into GLP-1 receptor agonists. So medications that could act just like the GLP-1 that we naturally produce. And then as those medications began being produced, we saw benefits for diabetes, and then we saw benefits for a lot of other things, and the main one being weight loss. So as we did more studies on diabetes, we saw in those studies, we also saw weight loss. And then there were more studies being done on weight loss itself. And they found that in order for a GLP-1 receptor agonist to induce diabetic effects and weight loss effects, you could use different doses, some higher, some lower, depending on the effect that you wanted. And then currently, there's a lot more research on other benefits of GLP-1 receptor agonists. So the two biggest ones that I've seen right now are cardiovascular complications. So it appears that the GLP-1 molecule itself is an anti-inflammatory. So it will suppress the production of specific molecules that may increase inflammation, which in this case may increase vascular damage and may be increasing the risk of cardiovascular complications. So the GLP-1 receptor agonists being anti-inflammatory, we see they're reducing the events or the number of cardiovascular events and cardiovascular outcomes in, especially in diabetics, but in most of the population that they're studying them on. So there's some new research avenues. And the other one is it appears that giving GLP-1 receptor agonists to elderly who are suffering from age-related muscle loss, it appears to have a preserving effect for muscle mass. It's because the GLP-1 molecule itself has receptors on the muscle that may increase muscle protein synthesis or at least the sparing of amino acids for muscle growth. So there's a few different research avenues that are going down right now, which will probably extend the amount of time that these drugs can stay patented on the market, which may or may not be a good thing depending on who you ask.
That's a really good statement there at the end. I'm curious about a couple of things. So, firstly, in regards to the retention of muscle mass, many of the current studies that are being done do actually, I think, from what I read in the literature, it is shown that some of these people, the study participants, do lose muscle mass quite to a large extent as well, along with all the fat that they're losing. So the muscle retention aspect must not be super high of GLP-1. Is that correct?
Yeah, so it's not going to have an anabolic steroid effect, but what we do see is that in the studies where there's a large degree of muscle mass, we also see when we look at the actual food these participants are eating, they're extremely hypocaloric, meaning they're in a very large caloric deficit, and a lot of times they're very low in protein. So if you're not very hungry, one of the last things you want to eat ends up being protein. A lot of times the thing you're hungry for is a simple snack or some sort of carbohydrate or dietary fat. So we see that the protein percentage in their diet also radically decreases. So I would like to see some studies where we're trying to control protein intake and trying to at least get to at least close to maintenance calories, not maintenance calories because we want them to continue to lose weight. But if we can get them into a protein adequacy or a nitrogen balance, then we can see how that actually affects muscle growth and have these participants exercising. A lot of these participants don't end up exercising within the study because they want to control for as many variables as possible. So we do see muscle loss in some of these trials, but I wouldn't necessarily blame that on the GLP-1 receptor agonist itself, especially in the face of some of the research in which if we give GLP-1 agonists, there is a muscle preservation effect. And some of the research we know about GLP-1 agonists themselves having a muscle sparing effect. So if we can get these participants, especially people taking GLP-1 receptor agonists, to stay adequate in protein and to resistance train, I think we'll either see at least a maintenance of muscle during a weight loss phase, which is definitely a win. And every once in a while, you might see a few participants who will gain a little bit of muscle. I think it's hard to blame the muscle loss on the medicate or on GLP-1, the molecule itself, but rather the way it alters their dietary habits.
That's a really good point, and especially like the protein, pointing that out. So for anyone listening who is taking any of those drugs or considering it as well, I mean, having adequate protein intake and doing some resistance training is great while you're in a deficit anyway. And of course, regardless of that, at any stage in life, as you and I both know. The other thing that popped out to me was kind of in regards to the dosage. So you mentioned that there was some some variation in there between the studies. And I'm curious, like now with things like the ones that are a lot more available to the everyday sort of person, let's just say, what's the dosage there like? And are people do they have to be cautious when they kind of self-medicate? Should they rather work with a professional or what's the read there?
Yeah, so there's kind of two brand names for the same molecule. So we have Ozempic and Wegovy. They're produced by the same company. Ozempic is the medication for diabetes, and you start out at a lower dose, typically about a quarter of a milligram a week, and then you will progress upwards to they try to cap it off around a milligram a week for diabetes or diabetic control. So that's Ozempic, and then Wegovy is a higher dose. It will cap off around 2.4 milligrams per injection per week, and that is the dose that they're giving. It will certainly help with blood glucose control, but it's also much more targeted for weight loss. So it's a little bit higher for weight loss and a little bit lower for diabetic control. The one thing to think about is as we get higher and higher, the side effects get greater and greater. So all doctors, at least they should be trying to keep each participant or each patient on the lowest dose possible so that they can get the most benefits with the least side effects.
That makes complete sense. And in terms of the side effects, what are some of the side effects that we are seeing with them?
Yeah, so the biggest side effect, so one of the biggest effects of GLP-1 receptor agonists that is noticeable almost immediately is that it will slow down gastric emptying. So when we take a GLP-1 receptor agonist, or even after a meal, when we produce GLP-1, the speed in which food moves through the gastrointestinal tract will be reduced. And if we have a GLP-1 receptor agonist inside of our system all week long, and there's really no breaks in between meals, we see a very large reduction in gastric emptying, which can cause things like constipation and bloating. And for some people, if taken incorrectly. So if they're not under the supervision of someone intelligent, then they might be taking too much or too often, and they may see that their gastric emptying reduces so much that they get what's referred to as gastroparesis, which is kind of the paralysis of the gastrointestinal tract. And that's recoverable in certain cases, and in some cases it's not. So there are some side effects there, especially with gastrointestinal disorders, that you want to look out for. So trying to, again, be on the lowest dose possible so that we're not sacrificing gastric emptying speed for weight loss. Um, so that's the biggest one. And with a slowing or a reduction in gastric emptying, especially also with the large increase in satiety, some people begin to feel nausea. So if you think of having a very large meal, you got a lot of food in your stomach, and your brain's like, oh man, I don't want any more food. Sometimes you get a little bit nauseous. So that, if you could imagine that being 24/7 after taking a medication, or at least for the next 7 days, then you can see that you might feel a little bit nauseous. And that's one of the most common side effects. So the biggest side effects end up being those two. There's some other hypotheses, but most of them are in animal studies and they haven't really borne out in human research. So I wouldn't necessarily jump to any other big conclusions, but nausea and just basically a lot of food sitting in your stomach after you've eaten, those are the two big ones. And then if we see people are radically reducing their caloric intake and their protein intake, they may be one, losing muscle because of a deficiency in protein, and two, they may be having deficiencies in micronutrients at that point. So that's another thing to think about if your meal consists of, or if your diet consists of 1,000 calories a day, very difficult to get all of your essential nutrients, especially for someone who's already a larger person. It's hard for them to get all of their essential nutrients in just 1,000 calories. So some people will face the risk of micronutrient deficiencies on these medications simply because they're not able to consume enough food, or they're not tracking their food strictly enough or taking a multivitamin in order to get the nutrients that they need.
Yeah, that's a really good point. I think something a lot of people don't think about, and another reason why, in my opinion, it is best to work with a medical professional when diving into these drugs. And that brings me to another point, though, of well, sustainability, or however you want to call it, in the sense of, let's just say, if someone has lost all that weight, do they then need to slash, like, how much is the rebound of what we see in the literature, or do people just need to stay on that medication?
Yeah, so I would say there's a lot of things it's dictated by. So depends on how you get off the medication. So there's obviously there's a multitude of different strategies, and it really depends on the person and what they choose to do. So if you take the medication, you get off the medication, and you go back to exactly what you were doing, typically in those participants, we see about a 50% or more regained in weight, and some of them gain all of the weight back. There's not really much data to indicate that they gain more than they lost, but there is a lot of data to say that they will gain the weight back if they simply just go back to what got them there in the first place. There are strategies to taper off or taper down the medication, so going from maybe a Wegovy dose of 2.4 milligrams to an Ozempic dose of 1 milligram, so tapering down, or even some people. So the starting dose ends up being about a quarter of a milligram a week. So if we started at a quarter of a milligram, and we try and taper back down to a quarter of a milligram, it's really not that much medication you end up injecting, and it may still help to maintain that weight loss. We can go right back into, so one strategy that I've used on a few people who are trying to taper off of the medication is going from the medication to trying to boost their natural production of GLP-1 through dietary strategies. So as we said, there's a lot of strategies, dietary components that increase your production of GLP-1. So if you can basically replace what you are injecting with your natural production by changing your diet, if you haven't already done that already, then that's going to help maintain the weight that was lost. So it depends on how you go back into your dietary strategies after coming off or tapering down the medication.
I love that. Could you share some strategies with us in order how we can boost our GLP-1 naturally?
Yeah, so the big things for GLP, so one interesting thing is the cells that produce GLP-1, they're located farther down in the gastrointestinal tract. So there's cells that produce different hormones located higher up in the small intestine. And as you get to the bottom portion of the small intestine and the top portion of the large intestine, that's where the cells that produce GLP-1 are mainly concentrated. So if we think about it, we don't want to be consuming too many foods that are rapidly digested, because if they're digested before making it down to the bottom portion of the intestinal tract, the GLP-1 response to that food will be diminished. So it appears that consuming foods that are more complex in structure can help boost GLP-1 production. So simply switching from mashed potatoes to whole potatoes, or switching from a protein powder to a whole food protein, or from an oil to a whole food fat like an egg yolk or an avocado. Those are a few strategies that can increase GLP-1 production. So whole grains and complex carbohydrates are typically better than simple sugars when it comes to increasing GLP-1. We see that a higher protein diet in general can increase GLP-1 production. There's also some data to indicate that unsaturated fatty acids are a little bit more potent than saturated fatty acids for GLP-1 production. But the nuances there are the magnitude of difference is a little bit unclear. So I'm not going to say that if you switch all of your fats from saturated to unsaturated, then you're going to get a massive benefit. But it's something that is a little bit, there's more research coming out on it. And then there's polyphenols and antioxidants. So mainly polyphenols found in foods that have GLP-1 stimulating effects. So green tea polyphenols and some of the polyphenols found in coffee, as well as the polyphenols found in spicy foods, the capsaicin, that also is potent at stimulating GLP-1. So polyphenols are mainly found in colorful fruits and vegetables, or just colorful foods in general. So we're thinking about fruits, vegetables, a variety of them. And then some animal proteins such as salmon and many fish have specific polyphenols. There's some data to indicate that the omega-3s found in fatty fish and some in plant sources can also stimulate GLP-1. And then the last thing that is probably potent is fiber. So there's a difference between fatty acids and short chain fatty acids. So fatty acids we would consume dietarily, and short chain fatty acids are produced inside of our gastrointestinal tract. They're produced when the bacteria in our large intestine ferment dietary fibers. So those short chain fatty acids can bind to receptors on the cells that produce GLP-1 and stimulate GLP-1 release, which is why, despite fiber having no energy content whatsoever, it does appear to have an appetite suppressing effect. That's one of the many reasons. So dietary fibers, especially those that are fermentable, appear to increase GLP-1 production.
Awesome. Well, I think really great practical tips for people, just for anybody, to increase their satiety, but particularly also when we are trying to lose body fat. I'm curious because sometimes you hear of people that are reasonably fit, reasonably trained, and so on, and they're kind of like quote unquote microdosing with these things. Is there anything in the literature or anything that you have come across in the sense of longevity help or even dangers potentially that would pose some indications for this?
So it's tough to say dangers other than the things we discussed about, protein inadequacy and micronutrient inadequacy. So if you're long term on a very hypocaloric diet, if you're losing muscle and you're deficient in micronutrients, that's something to think about. But typically, people who are taking these receptor or these medications for longevity purposes already have a lot of other stuff dialed in correctly. One thing when it comes to longevity is, again, I said the anti-inflammatory effects of these medications, that we see reductions in blood pressure, in cardiovascular outcomes, and there's some neuroprotective effects, so some cognitive protective effects, so reducing the risk of things like Alzheimer's, dementia, and other neurodegenerative disorders. So we see that these medications may essentially just reduce the risk of chronic disease or diseases that develop as we get older. So there's some efficacy for them, but it's a lot of times we have to think about doses, what doses get which results, and then which side effects come with those doses. So if I don't know this specifically, but if we see cardiovascular benefits at a large dose, but we also see all those side effects at a large dose, then you have to, it's basically a cost benefit analysis. But I believe that some of the cardiovascular trials are looking at lower doses of about typically less than a milligram a week. And we're seeing anti-inflammatory and cardiovascular benefiting effects. So there might be a longevity purpose of these medications, but there's not, they simply haven't been on the market enough for us to see long-term, lifelong, how they affect all-cause mortality and specific disease mortalities. Because someone with diabetes might die of different complications than someone with no other known causes. So for someone with diabetes, it might be a longevity strategy. But for someone who doesn't have diabetes, someone who is just a normal person, there might not be any longevity benefits.
I think that's such a great way to phrase it. So thank you for putting it that way. And overall, I know you go very deep when you are looking at any of your topics. And what was one of the things or some of the things that surprised you the most about all this literature, whether it's in regards to GLP-1 naturally or just in regards to the drugs?
Yeah, I would say so. That's a tough question. I would say the muscle protein effect was interesting to me. It's hard to when I saw that originally, it was hard to basically I came to the same conclusion that you did. Why are we seeing such large muscle loss in some of these trials compared to without the medication if they have a muscle protein sparing effect? But then we have to think about if we dig deeper into the specific macronutrients the participants are consuming, then we kind of understand why they might be losing muscle, and it's not necessarily due to the medication itself. So that was interesting, and I would personally like to see more research on it to see how they actually affect muscle growth. So simple, just looking at taking someone on a GLP-1 receptor agonist and someone off of it, doing the same, pretty much the same exercise program, and looking at fractional synthetic rate or basically muscle protein synthesis after exercise. So we can do those acute studies and see how it alters muscle protein synthesis or baseline muscle protein synthesis. So there's studies I would like to see in the future, but that was something that kind of caught my attention and something that I wish there was more research on. Another one, there is an artificial sweetener, or I guess you would call it a natural sweetener called allulose. So it's something that has now been demonstrated to increase GLP-1 production. So it's a non-nutritive sweetener, just like stevia or Splenda, that appears to have differential benefits. So it instead of just being inert and kind of passing through us, going in one end and out the other with pretty much no change other than the flavor, it does appear to have benefits for increasing GLP-1. And then there are some smaller studies to indicate there's a mild anti-inflammatory effect, some weight loss benefits, and some blood glucose control benefits. So simply just switching out, if you're using artificial sweeteners or non-nutritive sweeteners, then switching it to an allulose powder, which, mind you, you will have to use a little bit more allulose than you would a non-nutritive sweetener because it's not as sweet as them. Then we might also see benefits for just doing that. Might see some benefits for weight loss and blood glucose control. So those are probably the two big ones.
That's the very first time I have heard about this allulose sweetener. Is it a natural sweetener such as stevia or monk fruit sweetener, or is it an artificial one such as aspartame or sucralose?
To the best of my knowledge, is a natural sweetener like stevia.
Interesting. Okay, yeah, I will look more into that and just see how the mechanism potentially functions. I could imagine that it has to do with the fiber content or something like that. I don't know, or yeah, it sounds very interesting in any case. But no, you've given us a really wonderful overview over what GLP-1 actually is, what the drugs do these days, and how someone on the drug can offset muscle loss as best as possible, but at the same time as well, how we, if we're in a dieting phase and not on these drugs, can boost our GLP-1 naturally as best as possible. And yeah, in terms of like the future research, you mentioned you would like to see a lot more studies being done with the protein and with exercise and so on. Is there something else that really excites you at the moment in terms of upcoming research or things that you're working on right now?
Yeah, I think the biggest one is learning more about the side effect profile. So if we see in the future, we see issues with pancreas function or other organ systems that may be having an altered function, especially in the gastrointestinal tract due to long-term usage of these medications, then that's something that we'd have to want to know, and then basically put that into practice, trying to get people on and off of these medications as quickly as possible, or preventing them from getting on them in the first place. So I want to learn a little bit more about the side effect profile, and then I guess like we talked about, I would like to learn a little bit more about how the molecule itself affects muscle mass.
Mm. Awesome. And before we started recording, you mentioned that you were also digging deep into type 2 diabetes, I believe, overall. And you mentioned that there's some kind like a connection with, or that initially also these drugs were kind of designed for diabetes. Maybe you can kind of tease a little bit that connection and some of the research you've come across when it pertains to diabetes.
Yeah, so kind of quite simply is diabetes is a lack of blood glucose control. So we diagnose diabetes when blood glucose is elevated too high for too long. So we use a specific marker called HbA1c to diagnose diabetes. So diabetes is when we cannot control our blood glucose. And the main root cause of diabetes for most people is obesity and physical inactivity, because there are specific mechanisms by which body fat can induce insulin resistance, that hormone that we talked about that lowers blood glucose. If it induces insulin resistance, then the blood glucose stays elevated. So the main root cause of insulin resistance ends up being excess fat accumulation. And then with that, physical inactivity can exacerbate that. So we see that weight loss in and of itself from these medications can help improve insulin sensitivity, which in and of itself would reduce blood glucose. But we also see that these medications, again, they increase insulin production. And if one of the simpler ways to overcome a resistance to a molecule is to produce more of that molecule. So temporarily, as we get on the medication, we see reductions in blood glucose simply because of a higher insulin production can help facilitate more blood glucose control. And then as we stay on the medication, when we see weight loss and anti-inflammatory benefits, those also improve insulin sensitivity, meaning we again see improvements in blood glucose. So GLP-1 receptor agonists were developed for diabetes, not necessarily because they induced weight loss, but rather because they can help increase insulin production, which is a lot of diabetics are just taking insulin to control their blood glucose. But then we see that they're also reducing body weight, which can reduce the need for insulin mimetics or insulin injections themselves. So there's a lot of benefits to GLP-1 outside of just insulin production in reducing body weight.
Awesome. That sounds very promising. Forgive me, you might have said this, but this is mostly being used for type 2 diabetes. Wouldn't obviously affect type 1 diabetes too much in terms of
Yeah,
the.
so type 1 diabetes occurs because the specific cells in the pancreas that produce insulin have essentially died, or they're unable to produce insulin. There's a few different genetic causes. And because GLP-1 would bind to a receptor on those cells and stimulate insulin production, if those cells aren't functioning properly, a GLP-1 receptor agonist won't do anything to alter insulin.
Yeah.
So the way that type 1 diabetes is controlled is by injecting the insulin that you should be producing. So GLP-1, they won't help there, but there's a lot of inflammatory effects of type 1 diabetes that GLP-1 receptor agonists can help control. We would probably want to use stronger medications for that. And there are situations where people get what's referred to as double diabetes. So type 1 diabetes that also has an insulin resistance component. So it's type 1 and type 2 kind of combined with one another. So in those scenarios, again, that would be caused almost primarily by excess body fat. So in those scenarios for inducing weight loss in type 1 diabetics, they could have efficacy, but it's very difficult to kind of guide someone with type 1 diabetes through that due to the way that they're injecting insulin. It's just there's a lot of things you'd have to be controlling at the same time, and it's a little bit of a risky game to play.
That makes complete sense. Well, thank you so much for teasing that. We're going to stay tuned for your review on that in the Alan Aragon research review. And if someone wants to find you and your content, where can they look you up? I'm going to put it in the show notes also, but still give it a shout out.
Yeah, so I have an Instagram that's Calvin underscore Scheller. Scheller spelled Scheller. And then I have a TikTok, which is basically it's very similar to my Instagram, which is where all the original videos are filmed, and that's Physiology with Calvin.
Awesome. Love it. Super cool. Thank you very much for your time and all your wisdom, Calvin. It was a pleasure speaking with you again.
Yeah, thank you for having me.